Welcome, everybody. We'll get started here. Thank you for coming to this talk this afternoon on what to know about rotator cuff injury. I'm Sean Marks, an orthopedic surgeon here at SSM Health at St. Mary's in Jefferson City. I've been here for about 4 months now, and so far it's been great. Love the time here. And as we get started here, if you have any questions along the way, you can just send them into the chat box and we can address them at the end of the presentation. A little bit about myself. So I grew up in upstate New York originally, and from there I did my undergraduate at University of Notre Dame before returning back closer to home for both medical school and residency in upstate New York. And then I did a fellowship in sports medicine at the University of Kentucky. Of course, growing up in New York, I'm a big time Buffalo Bills fan. And we've already got our daughter on the bandwagon, but don't let the smile fool you. She can get pretty nasty when the going gets tough. So what we want to understand today is essentially the rotator cuff, what it is, how do we injure it, why is it that it becomes a frequent source of pain for us, and how do we test it both in the office and other tests such as imaging studies that can be done outside to help us figure out a little bit what's going on and how do we treat it. So as you listen, you'll find out that it's pretty nuanced when it comes to evaluating the rotator cuff. Not all tear is the same, not all injury is the same, and so we have to take each of them individually. And I think that's what the fun part of shoulder surgery and rotator cuff surgery is really tailoring the treatment and diagnosis to the patient as they come in. So we'll start off with a little bit of the anatomy. The bones that make up your shoulder, the two primary ones are your humerus, so your arm bone, and then your shoulder blade, and that forms a ball and socket joint. And then, of course, your collarbone comes in and kind of acts as a little bit of a strut to the shoulder to hold it out away from your body. All this is to say that you see there's a little bit of roundness to the humeral head and a little bit of a dish side to the socket. And so that adds a little bit of stability, but really it's that lack of a socket that goes all the way around the humeral head that allows us to get our arm all the way up overhead, reach behind our back. And we have a series of ligaments that help out with us. And then the muscles and tendons about the shoulder are really what we're talking about today. And there are 19 of them. So we'll go over those briefly, but there won't be a test at the end, so you don't have to worry about that part of it. But why is the rotator cuff a frequent source of pain? Well, we think it's because of this small interval that the rotator cuff runs through. So we'll see some pictures a little bit later, but the muscles attached to your shoulder blade, and then it's a series of 4 tendons that come across the front of the shoulder, the top, and around the back. And up on the top part of the shoulder, they go through this narrow area between the acromion up top, so that's the bone that you can feel on the outside of your shoulder, and your arm bone. The distance of that is about 10 millimeters, and the thickness of your rotator cuff is also about 10 millimeters. So there's not a lot of margin for error. When we reach our arm up overhead, it can kind of get squished between those two bones, and over time it can wear it out a little bit. When your tendon becomes inflamed, it swells some, and that also fills up a little bit more of the space. So it's a tight space that it's working through. And so your shoulder muscles, these are the ones that most of us know. And if we go to the gym, these are the ones that we're working on. I call them our outside muscles because it's the one we want people to see. So if we're lifting weights, we're working our biceps, our shoulders, our pecs. But a lot of people forget about the other 12 muscles around the shoulder. And I call these your inside muscles. And these 4 in particular are what make up your rotator cuff. So your subscapular, supraspinatus, infraspinatus, and teres minor. The names of them aren't necessarily important, but understanding that it's a sheet of tendon that essentially wraps the humeral head like the cuff of your shirt would. So if you take your shirt sleeve, if you unbutton the bottom part of it and look at it from the outside in, then the bottom is open, comes around the top, and comes around the back, and the bottom is open again. And so that's what your rotator cuff looks like. It's one tendon in the front of your shoulder, 2 on top, and then one that comes around the back side of it too. And they all start to merge together. And so finding the definition from where one tendon ends to the other tendon begins can be a little tricky because they start to converge onto each other. This is what it looks like during surgery. So this is putting a camera inside the middle of the shoulder, and now we're down in the shoulder joint and we're looking up at the rotator cuff. And it looks like this nice white sheet, kind of like a wave crashing on a beach and attaching to the outside of your arm bone. And so this is an intact rotator cuff, and then here's a picture of a torn one, so a big hole right through the middle of it. And when we're talking about rotator cuff tears, this picture here is frequently what we're talking about. So the function of the rotator cuff, it does a few things. It helps depress the humeral head, keep it centered on the socket part of the shoulder, on the glenoid. And that allows your deltoid, the big muscle on the outside part of your shoulder, to function properly by maintaining a stable fulcrum at the glenohumeral joint. And it also confers some stability. So remember the ball and socket joint, it's less of a socket and more of a ball and a dish. So it doesn't have a lot of room to play. And those rotator cuff tendons help add some stability to it by maintaining some strength in and around the shoulder. And so this is what a normal shoulder x-ray would look like. Notice that the humeral head is centered right on the dish over here versus an x-ray in which someone has had a major tear of their rotator cuff. All of a sudden, the humeral head is drifting upward. And if you remember that bone from before, the acromion, now it's butting its head up against it. And so that's the function of the rotator cuff, is to keep it depressed down. And when you lose it, it starts to drift upward. And when you don't have a rotator cuff, then your shoulder muscle, your big deltoid muscle, all of a sudden you end up with a shoulder shrug and you're not able to get your arm up away from the body and up overhead. So the diagnosis, this is kind of going through what does a typical exam and the visit or office visit exam look like. So we start with the history, how did it happen, move on to a physical exam, and then consider different imaging studies to help us see in a little bit more detail what's going on. And so the history of the injury is really important to me. Is it something that, boom, happened all of a sudden? We see it a lot with people falling, whether it's falling and catching yourself off a ladder, dogs pulling on leashes, all of a sudden it brings your arm out into that extended position, or catching yourself on an outstretched arm when you fall. That's the most common way to tear your rotator cuff traumatically. But the most common rotator cuff tears are actually slow onset wear and tear over time. And you might notice it acutely, but it could be something that's been going on for years and years and years, just from wear and tear, repetitive tasks, working overhead. So we see a lot in construction workers, farmers, people who are doing woodworking, weightlifting, those types of activities. The location of the pain is important to me. Rotator cuff pain typically shows up on the outside part of the shoulder. And a lot of times people will come in saying, no, it's not my shoulder that hurts. It's down here. And that for me is a telltale sign that the problem is up at the shoulder and most likely related to your rotator cuff. Pain that's up closer to the top part of the shoulder and your neck, usually that is not coming from the rotator cuff. It can be due to some other issues, frequently related to the neck. And then with worse injuries, worse tears, we often have people coming in saying that they're having a difficult time sleeping at night. So physical exam, one of the things I really want to see is your range of motion. Can you get the arm all the way up overhead? Can you reach it behind your back? It might hurt while doing so, but if you're able to do it, that tells me at least your rotator cuff is functioning the way it should be. In really bad injuries, we see something called pseudoparalysis, where you might try to reach your arm up overhead and it just doesn't go. And it looks like maybe the nerves aren't functioning correctly, but that's not correct, because then you can actually lift their arm up overhead. Once you get it there, they can hold it there. But as you come down, all of a sudden it drops down by their side. And that tells me that you have the range of motion, you have the nerves that are intact, but the tendons aren't there to actually help you get up overhead. And then the next most important thing really is strength. So can you push out against me in all the different directions that those rotator cuff muscles function? And then atrophy, you can actually see if it's been torn for a long time, you can see if some of those muscle bellies are starting to wear out. And then palpation, so just pressing in and around the shoulder, a lot of specific places that I test for, including some of the smaller joints around the shoulder and where some of the smaller tendons roll. And then how are you sitting? Are you sitting with your arm in a protected position? Do you have good posture? I don't, so don't pay attention to how I sit, but that's something that I'm paying attention to from the time I'm meeting you. And then everyone who comes in, I do always get a series of x-rays because even a normal x-ray means a lot to me. It rules out, a dozen things that could be going on in your shoulder. And so this is a normal x-ray here, the arm bone, the socket side, and your collarbone coming in versus the x-ray we already saw earlier where, oh shoot, now the ball is starting to butt its head up against the undersurface of the acromion here, and that tells me that we've got a major issue. And so the discussion I'm having with the patient with the normal X-ray is a lot different from the discussion I'm having with a patient who comes in with this X-ray over here. Ultrasound can be useful to look at the rotator cuff. It's cost effective in the sense that it's not as expensive as an MRI, but there's less reliability with it as it's often dependent on who is doing it. And so unless you have someone who's doing these day in and day out, it can give you mixed results. So a lot of times if we're concerned about a rotator cuff tear or we really need to rule out and make sure that the rotator cuff is still intact, then we'll order an MRI, which is a study that lets us look at the ligaments and tendons in and around the shoulder. So x-rays and CT scans let us see the bones, and the MRI will let us see muscles, tendon, ligaments, and gives us a lot of information to look at. And the shoulder is a complicated joint. There's frequently more than one thing going on, and that really gives us the detail that we need. A CT scan can be helpful in folks who cannot undergo an MRI for whatever reason it might be, whether they have an old pacemaker or something else. We can inject some dye into the shoulder, and that'll give us a clue here. So this is the arm bone on the outside, the socket, and then the dye is this bright white. And ordinarily, if you don't have a rotator cuff tear, it should stay just in this area. But if you have a rotator cuff tear, then that liquid starts to seep out, and we see it kind of coming through this area and all the way on the outside of the arm. So rotator cuff injuries, they really run a spectrum from tendonitis, bursitis, impingement. I kind of put all of those in the same category. I use them interchangeably. They're technically different, but the treatment for them is very similar. Versus a rotator cuff tear, is it new? Is it old? Is it partially torn? Is it completely torn? And how big or how bad is it? And then rotator cuff arthropathy is kind of the end of the spectrum. So that's where you've had a rotator cuff tear that's been present for a long time, and now you're starting to develop arthritis on top of that. And so really it's a spectrum of disease, and we'll kind of go through each of these a little bit individually and talk about what that means as far as your treatment goes and everything like that. So rotator cuff tendonitis, like we said, shoulder impingement or bursitis are kind of the common entities. And by far, it's the most common thing that I see in the office is either tendonitis or shoulder impingement. And there was a long time when we were doing surgeries to shave down a bone spur that was pushing down on the rotator cuff tendon and kind of collapsing that space between your acromion up top and your humeral head down below. We know that a lot of times you don't actually need to do a surgery for that anymore, and a lot of people will get better with physical therapy, some injection, some anti-inflammatories. And so shoulder surgery for rotator cuff tendonitis has pretty much become a thing of the past. Rotator cuff tears, however, are a little bit of a different story. And really, we have to think about where they are, what they are, when did it happen, how big is it, how bad is it, can your arm function currently, and what can we actually do about all of those things, whether it's restoring pain, function, whatever it might be. So anatomic, we think of in a few ways. Most common is thinking about which tendon is torn. So the supraspinatus tendon is one of those rotator cuff tendons that sits on the top of the shoulder, and that is the one that's most commonly torn. Your infraspinatus, subscapularis, and teres minor can also be torn less frequently, but as you're starting to involve those additional surgery, those additional tendons, and the injury becomes a little bit more complex. And then we want to think about your functionality. So can you get your arm up overhead? Do you have strength overhead? So if you're a construction worker, can you still hold a drill while you're working overhead? Or do you get up there and it fatigues easy and all of a sudden you're trying to support yourself with the other arm like you weren't doing, a month ago, a year ago, whatever it might be. And then we have to think about the size of it. So is it one of these little small tears, medium, large, massive? We measure them, and that will give us an idea of kind of how big and how bad. And these large and massive ones can be the really challenging ones. And then is that tear all the way through the tendon or just part way? So we have to think about the tendon, not just in its circumference, but also in its thickness. So is it torn part of the way? Is it torn all the way through? And if it's only torn part of the way, is it tearing from the inside out or the outside in? That tends to have different implications as far as our treatment strategies and how painful the shoulder is. And then is it a high grade or low grade tear? So is greater than 50% of that tendon torn in its thickness or less than 50%? And that'll help us determine what to actually do if it comes to surgery. And chronicity. So did it just happen or is it something that's been going on for months or years? Rotator cuff tear progression is always a topic of conversation in the office. A lot of patients want to make sure that they're not going to make anything worse. What we know is that kind of the rule of thumb is 50% of partial thickness tears will become a full thickness tear 2 years down the road, and 50% of full thickness tears will increase in size 2 years down the road. So we don't know what bucket you're going to fall into. It's kind of a flip of the coin at that point. But I would think that some of the activities that you're doing, if you're continuing to work overhead and do heavy lifting, pushing, pulling, that will confer a little bit more risk as to those tears progressing in time. And then kind of the end of the line we talked about some already is rotator cuff arthropathy, which is really the development of arthritis in addition to a massive rotator cuff tear. And so on the left side of your screen here is a picture of shoulder arthritis, where all of a sudden that space that's normally present between the ball and the socket, that's completely gone, and you're starting to develop these bone spurs. We call this bone spur down here a goat's beard for obvious reasons, versus a rotator cuff tear where the shoulder is starting to butt up. When you put those two together, you get rotator cuff arthropathy, where now we've lost that space and the cartilage between the head and the socket, and now it's starting to butt up against the undersurface of that acromion there, and it's actually starting to wear away in kind of the same pattern as the humeral head. So again, a spectrum of disease. Here on the left side of the screen, impingement, bursitis, tendonitis. These are the things that are typically seen most commonly in the office and often respond very well to physical therapy, anti-inflammatories, and injection. Partial tears or small complete tears, those ones we frequently start with conservative treatment, and then if it's not getting better, we have a little bit different discussion about surgery, versus these larger tears or these acute traumatic tears. A lot of times you'll be having some dysfunction, whether it's pain or weakness with certain motions, that we often try to treat these with the surgery. And then rotator cuff arthropathy is kind of the end of the line. So over on the left side, you're waiting on the platform, and then in this middle area, the train is starting to leave the station, and it's only heading in one direction, but we don't know how fast it's going. So if we're traveling from New York to LA, you may never get to LA. You might get off in Kansas City or St. Louis, and you never progress all the way down this pathway, and we might get you by just fine for years and years and years if you have these smaller tears. So treatment, rest, so avoid the aggravating activities. It sounds obvious, but I have a hard head just as much as other people do, and I've had injuries in the past where you just keep trying to push through it, and all of a sudden months go by, and you've noticed it's just gotten worse and worse and worse before you finally, take a break from some of those things. Ice, heat. I typically tell patients to try whichever one works best for them. It is a little bit of trial and error. If you like heat better, that's great. If you like ice better, that'll help too. Anti-inflammatories, ibuprofen, Aleve, over-the-counter stuff, or the prescription medication that I typically use is meloxicam because it's once a day. It's in the same family. So it's a little bit easier to remember to take it on a regular basis. And then injections, typically we're talking about steroid injections into the shoulder. We don't want to pump the shoulder full of injection after injection after injection, but one or two here or there just to tamp down that pain and inflammation, I think is really helpful so that you can get started in physical therapy, which is really the key to a lot of shoulder pain and shoulder injuries. Remember, there are 19 muscles that attach all around the shoulder, collarbone, shoulder blade, your arm bone. And so getting all of those to work in concert and work together as you build a strength and coordination through that typically relieves a lot of the shoulder pain that we're having. And then shoulder surgery, We can talk about rotator cuff debridement, so just kind of cleaning up those partial tears if they're small and low grade, repairing it if it's more of a high grade partial tear or the full thickness or large or massive tears, then we're definitely talking about repairing those. And then shoulder replacement is really reserved for kind of that end of the line rotator cuff arthropathy. Um, so again, physical therapy is really the cornerstone of treatment, focusing on strengthening the muscles of your rotator cuff. Remember, the job of the rotator cuff is to keep the ball centered on the socket. And as the rotator cuff becomes weak or torn, that ball starts to drift up a little bit. And that space that the rotator cuff lives in gets narrower and narrower. So it becomes one of these things where it can just spiral itself out of control. And by building that strength, all of a sudden you're making that space a little bit wider. So now when you're reaching up overhead behind your back, your rotator cuff isn't getting pinched in your shoulder anymore. And that's where a lot of that pain comes from. And so physical therapy is a lot of resistance band type exercises, posture exercises, and correcting how your scapula moves in relation to your arm bone. And then anti-inflammatories, injections, ice and heat. Shoulder arthroscopy is really using small incisions in and around the shoulder and putting a camera inside the joint to look around and repair or fix anything that we need to. Typically, it allows it to be a little bit more less invasive and allows us to see a lot better because that camera, we can move it around into all the little nooks and crannies and really see in great detail what is happening in that shoulder. The downside of shoulder surgery and shoulder rotator cuff repair in particular is the recovery side of it. So the surgery might take an hour and a half, 2 hours, in and out, same day. But we don't have great ways to cheat biology at this point. And it takes really 3 months for the rotator cuff tendon to fully heal. And so a lot of times we'll put you in a sling for 4 to 6 weeks. You start in physical therapy after that. But it's really not until 3 months that you're starting to do some real strengthening exercises and can be 4 to 6 months before you're doing any heavy lifting, pushing, pulling again. And then a subacromial decompression, if it looks like that space that's on the undersurface of the acromion is getting a little narrow, then we can shave that down to create a little bit more space for you. And so a few pictures that show what we're talking about: small incisions in and around the shoulder, and then anchors that go into the bone. And to those anchors are attached some suture. And so those sutures are passed through the tendon, and then they're either tied or held in place with another anchor around the shoulder. So again, intact rotator cuff tear. This is looking from the undersurface of the rotator cuff. So when we're doing that surgery, we actually look at that tendon as a sheet, both from below, so we're looking up at it, and then we move the camera and we look at it from the top and look at it from above. And so this is the below picture here. This is the above picture. And again, this is your rotator cuff over here and a big hole right in the middle of it. And then we pass sutures to cover that up and bring it back down to the bone to allow it to heal. Reverse total shoulder arthroplasty is reserved for rotator cuff arthropathy. So these rotator cuff tears that either can't be repaired or they've been present for so long that you're developing a significant amount of arthritis in that shoulder. It is a great procedure for pain relief, and a lot of people get very good function afterward. And so this is a patient of mine I had a while back where, as you see this x-ray, like we saw before, the humeral head is butting up against the undersurface of the acromion. And so now the reverse shoulder replacement is named that way because we put the ball on the shoulder blade side of the shoulder. And now we put the socket attached to a metal stem on your arm bone. And that allows us to stretch out your deltoid muscle, bring it back into good tension, and that'll allow you to reach your arm up and overhead again. And so this is one patient. He is 3 months after his surgery. Not everybody gets their arm all the way up overhead like that, but a lot of people do. And that's ultimately the goal of it, is great pain relief and improve function to get up, reaching your arm overhead. So the rotator cuff, to wrap up here, these are the questions we set out to answer at the beginning. What is it? It's a series of 4 muscles and tendons that help stabilize and move the shoulder. They come out from the shoulder blade and attach on your arm like a cuff of your shirt sleeve, from the front to the top, around to the back. How is it injured? Overuse and traumatic injuries. The overuse injuries are more common. The traumatic injuries are more worrisome in the sense that a lot of times they come in after a big injury in which you're then losing strength and function in that shoulder. Why is it a frequent source of pain? That narrow interval for the tendon and the complexity of the motion in and around the shoulder. We test in the office by asking you questions, making you move the shoulder for us, even if it hurts, testing your strength, your range of motion, and all the different areas, because all of those points are important to me in my decision-making process. And then what other tests can be done? X-ray, MRI, CT scan, ultrasound, and we treat it various ways from non-surgical anti-inflammatories, injections, physical therapy really being a cornerstone of it versus surgery in which we can do either a rotator cuff debridement, a repair, or replace the shoulder. Thank you for attending.